So by the end of this session, I hope that all of you will be able to describe the protective lung strategy, to describe the driving pressure, and to describe the lung recruitment. And at the end, I will apply the strategy on different lung diseases. Protective lung strategy has started around 20 years ago by the publication made by Amato in the New England Journal of Medicine. At that time, he compared between two groups of ventilated patients. The first group received 6 ml per kg as a tidal volume, and the second group received 12 ml per kg. He also limited the plateau pressure to less than 30 centimeter water, and he adjusted the fractional inspired oxygen and the PEEP according to tables. And he used the recruitment maneuver that we call now the fast recruitment maneuver, which is 40 centimeters for 40 seconds. All of the patients at that time were ventilated with a volume control ventilation. The result of this comparison between the two groups resulted in a difference in survival of around 22% in favor of the study group. And this was really an achievement at that time. After this, we spent 15 years of debate and of conflict, whether it is the volume or is it the pressure, is it the PEEP, is it the recruitment maneuver? Sorry, and nobody really knew which is the most important parameter of all these settings. I'm going to go briefly about these settings and to reach where we stand nowadays. So starting from the FiO2, we know that all of us now know that the minimum is the better. If you use the minimum concentration, it's the better. In this paper, they compare different concentration of oxygen, and the conclusion was that there is no significant difference in oxygenation index or functional residual capacity between the patients receiving between 80 and 30% oxygen for a period of approximately 5 hours. So the minimum, the better. We should go low, but if we are obliged and the patient require or is hypoxic, we are allowed to increase the concentration up to 80%. That was the first item in the protective strategy. The following item were the PEEP, the use of PEEP. In 2013 appeared the Cochrane systematic review that compared between the use of low PEEP and high PEEP in the patient of adult respiratory distress syndrome. And they concluded that the available evidence indicates that the high PEEP as compared to low PEEP did not reduce the mortality before the hospital discharge. There are no significant risk of barotrauma, and there is an improvement of oxygenation in both groups. And the included studies in this systematic review were characterized by clinical heterogeneity. What does it mean? It means that there are multiple modes of ventilation used and multiple parameter setting. And the most important, it was the type of patient or the selection of patients. So this was done on all type of patients with different pathophysiological diseases. Before appearance of this, there were another study presented by Brel. And in this study, he explained, or he gave us a clue on why did this heterogeneity affect the study. He found that patients with ARDS, a higher PEEP in them, it was associated with improved survival in this group of patients. So we know now that there is no difference in low PEEP or high PEEP in most of the lung diseases, except for the ARDS, and this was accepted from almost, or a consensus from all the people working in the ICUs. There were also another Cochrane study about the recruitment maneuver for adults with acute respiratory distress syndrome. And it concluded that recruitment maneuver for ARDS shows considerable heterogeneity also. So there are different co-interventions, modes, and plateau pressures, and PEEP. The evidence suggests that the recruitment maneuver may improve survival in the ICU. They are used predominantly as a part of an open lung strategy with PEEP titrated following the recruitment maneuver on an individual basis. And this is a very important fact. The best result from the recruitment maneuver is obtained when we use it in open lung strategy. We open the lung and then we maintain it open by the PEEP. So we need to titrate the PEEP to keep it open. Oxygenation improved for 24-48 hours after recruitment, and there are no increased incidence of barotrauma from the recruitment maneuver. And the largest study have used a PEEP plateau of 40 to 50 centimeter, but there are other studies that used even higher pressure than this. So these are the main three parameters which were taken in the protective lung study, other than the tidal volume and the plateau pressure, which were left constant as 6 ml or a plateau pressure less than 30. The last item was the mode of ventilation. All the patients at that time and all the patients included in the RDS network study were ventilated with, almost all of them were ventilated with a volume control mode. There is no one in the literature that could prove that there is a significant difference between volume control or pressure control. However, what I suggest is that we use both. It's not one of them. We need the volume control and we need the pressure control. I will prove that pressure control is better for these patients. However, we still need the volume control. And I will give you the explanation. When we receive the patients in the ICU, receive them at a late stage, all of them, they have a very low PO2, a very high CO2, and a high work of breathing. So you cannot clinically differentiate between them. But putting this patient on a volume control and looking at the pressure time curve or pressure scalar, you can see here that when the inspiratory valve open, there is a steep rise in the pressure, which is due to the resistance of the airway, and then a ramp made from the elastance of the lung until the volume is delivered. And here we reach the peak inspiratory pressure. If we delay the opening of the expiratory pressure, we obtain a ramp, and at that time, what we measure is the plateau pressure. And the difference between these two pressures is the gradient, and it usually is about 4 to 5 centimeters. Let's go now to the obstructive lung disease. What happened is that the plateau pressure remained almost constant, and the increase occurs mainly in the gradient. So the gradient became 6, 8 centimeter water, 10 centimeter water. And if we go now to the restrictive lung disease, we'll find that it is the plateau pressure that increases while the gradient remain constant. I believe this is a very important fact when we receive the patients at the beginning of ventilation to classify it, and also during the follow-up of the patient, because an obstructive patient might be infected or might have or aspirate. At that time, the plateau pressure will rise and we discover it. Or even a restrictive lung disease or patient might have an increase in the gradient due to bronchospasm, secretions, or kinked tube or obstruction in the circuits. So this is a very important fact that we can obtain from the volume control. Let's talk a little bit about and go back to the physics and physiology. that we studied during the college years, you see. I am going to remind you about Laplace law, which is the pressure inside the alveolus is inversely proportional to the radius of that alveolus, which means that two things. If you apply pressure to these two alveolus with different radius, then most of them will get the same pressure, but the volume maintained in each one of them will differ. The one with the higher radius will obtain the highest volume, and this will get the lowest volume. And again, the pressure initiated by these two will differ. This one is going to initiate a higher pressure because the resistance here is higher. What is the importance of this? This is also another study which is going back to the 70s, and in which they studied the stress distribution in lungs, a model of pulmonary elasticity. And if you apply pressure at that point here, they will be equal in both alveoli. But if you push volume, then the volume will go to the least resistance. The one with atelectasis will have the higher resistance, so most of the volume will go to the healthy alveolus. But what is more important is that most of the lung injury occur due to the stress occurring at this area between the two alveoli. Because if you use a pressure of 20 and you have a partially obstructed alveolus or partially collapsed alveolus, this pressure is doubled. So the pressure here, instead of being 20, it will become 40. If this alveolus is completely collapsed now, then the pressure is multiplied by 7. So you might reach a 140 centimeter stress against these points. And this is what makes the cracks at this area. And then you will get the surgical emphysema because air will go to the interstitium, and you will go to the interstitial edema, and you will initiate the production of cytokines and the injury of the lungs. So it is important that understand that applying a pressure will not increase the volume of this one, but it will not also introduce volume here, but it will be, the volume here is kept more or less constant in this alveolus. And this is a type of protection. The discussion for 15 years was about what the lung injury, was it a barotrauma or a voliotrauma? And we know now that there is no difference between both of them. Volume will produce pressure and pressure will produce volume. But for the other two, atelectotrauma or biotrauma, yes, atelectotrauma is what I explained just now. It is the swing in the pressure that makes the cracks and produce the lung injury. And this cracks later on will stimulate the biotrauma, which is the production of the cytokines that we are calling nowadays the cytokine storm. In the 15 years, there were some modulation in the protective lung strategy. So we know now that the tidal volume is around from 4 to 8 milliliter per kg. The plateau pressure has decreased to 26 centimeter. The FeO2, it's less than 0.8. The PEEP is titrated individually in the patients, and the recruitment maneuver we use what is now known as the stepwise recruitment maneuver, or the slow recruitment maneuver. And the mode of ventilation is becoming, the pressure is preferred in this patient. There is no evidence that this is better than that, but it is preferred in these patients. Why all this confusion for 15 years? I'm going to give you an example for how we were studying these patients. If we wanted to study a group of patients receiving 6 milliliter per kg, with another group receiving also 6 milliliter per kg, but we use a low PEEP here and we use a high PEEP here. Now, if we break the patient in this group, we find that there are two types of patients. Those where the PEEP might cause injury more than benefit, or what we call them unrecruitable, or those with the benefit more than the injury, which are the recruitable patients. If we get an average of these and then we compare, the result will depend upon the fraction of this group and the fraction of this group in this group of patients. So that's what made the confusion and made all the conflict or the debate in the discussions. That was the protective lung strategy, and it started with Amado in the 2000, and that was for 15 years. But after the 15 years, Amado returned again and published a new study, again in the New England Journal of Medicine in 2015, and where he mentioned that the driving pressure and survival in respiratory distress syndrome. And he reached that the driving pressure is the main parameter responsible for the improvement in the outcome or survival or mortality. What is the driving pressure? It is the difference between the plateau pressure and the PEEP. But if we take the compliance of the respiratory system, it equals the tidal volume divided by the pressure. So if we rearrange it, the pressure equal the tidal volume divided by the compliance of the respiratory system. So we come here to a very important equation, that the pressure is going to be the result of pushing a certain volume in a container that accepts that volume or does not accept that volume. If the container is accepting that volume, then the driving pressure is going to be okay. If it's not accepting that volume, then we are producing lung injury. The terminology used for these two events was the strength and strain. The strengths represent the power or the pressure used, and the strain represent the volume that results from this pressure, and or the volume and the deformity that occur in the container that received that pressure. One very mild, very important milestone in the advances or the progress in the series was published by Gattinoni in 2017, because he mentioned that it is not only the driving pressure with all the components, but it is also related to the respiratory rate and the time of inspiration or the flow. So if you use a pressure and it is applied to an alveolus, but you repeat it deeply, that might produce also an injury in the lung. I will facilitate this concept by giving you figures in the following slides, but first I would like to explain what Amado did. Amado did, what he did is that he grouped around 3,000 patients, a meta-analysis of 3,000 patients from all the people that were publishing the most at that time. Brochard, Slutsky, Brel, Amado, and he regrouped or he resampled these patients in groups. So the first resampling was matched by the PEEP. So he get all the patients that were receiving the same PEEP, let's say 10 PEEP. And then the second sampling was for the patient who received the same delta pressure. So the PEEP here is rising, the plateau is rising, but the driving pressure is constant. And the third group was matching the plateau pressure. So this patient, they have the same plateau pressure, but the PEEP used in them is rising. And then he went to the mortality of the population and he calculated the risk in each group. So he found that the mortality increases here while the PEEP was maintained constant. While the mortality here remained constant while the PEEP was rising, and the plateau pressure in both these groups were the same. So he reached the conclusion that higher plateau is not always risky, because it's not risky in this group, but it is risky in this group. And then he shifted to these two groups. In these two groups, we have a rising PEEP in both of them, but here the plateau is rising, and here the plateau is constant. And he found mortality constant and mortality decreasing. And he reached the conclusion that higher PEEP not always protective, because he did not protect here, but he protected here. So what is the common factor in all this group is the driving pressure. This is the group that maintained the mortality constant. And then he wanted to delineate the driving pressure. What is the pressure or the driving pressure that causes the increase in mortality? And he found that if the driving pressure is below 15 centimeter water, then the mortality is low. And if it is above, then the mortality started to increase markedly. So now he reached the conclusion that it's not the plateau, it's not the compliance, it's not the PEEP, it's not the volume, but it is the driving pressure. And if we bring it to what happened in the lung, we will understand that the driving pressure is the swing in the pressure. So whenever we have a marked swing in the lung, this lung is at a risk of injury. So this is to make you always remember what is the stress and what is the strain. That was taken from the championship in 1960 of the heavyweight of boxing between Muhammad Ali Clay and Liston. And Muhammad Ali won the world championship after 60 seconds in the first round by knockdown to Liston. So this is the stress. This is the pressure we apply to the alveoli. And our alveolar is the face of Liston. This is the deformity in the volume or the change in the volume that occur during the applied stress. And imagine that Gattinoni, if Muhammad Ali gave one knockdown after 67, if he gave Liston 10 or 15 ones consecutive, what will be the changes that occur in the volume here? Gattinoni, he published in his paper the way to calculate the pressure that we have to use in these patients. Don't be upset of this slide. I'm not asking you to retain this, but I'm going to show you, just to show you that it is related to the compliance, it is related to the tidal volume, the flow, the resistance, the PEEP, and the volume resulting from the PEEP. And then he added to this the respiratory rate, or the number of breaths, and the inspiratory time. And if we look now at the equation of the driving pressure, it is a simplification of all this equation that we are using here. And the resultant of both of them is this. If you try to introduce that volume in this alveoli, you will produce ventilator-induced lung injury. And it is known now during the corona time by the patient-induced patient self-induced lung injury. All of them are the same. It's a disproportion between what we want to introduce and the container. أو بحب أقوله بالعربي الفيل في الأبريق. لو عايز أدخل فيل في أبريق. That was the driving pressure. And this is the first part of my talk. We'll stop for a while, and then we'll resume with the second part with the recruitment and the applied strategy. And thank you very much for your attention.
Thank you very much, Professor Yehia. It was very, very nice part of the presentation, and I really enjoyed it. So if you kindly, the attendees, answer this poll here, and it's not an evaluation for Dr. Yehia Khater, of course, but it's something that needed for Saving Lives Academy, and Dr. Walid Al-Habashi is interested to see your response to this poll. So please answer it. While I'm preparing the questions to Dr. Yehia Khater, I'm very, very appreciating the simplicity of the presentation, and very nice, actually, very, very nice presentation. Thank you very much again, Professor Yehia.
Thank you.
And I think the message that everybody has to gain from this presentation is what we believe, that while we are ventilating patients, we have to be very concerned about how to protect this lung, not to make injury on top of the pathology that we already have. And not only on the pathologic lung, but also in normal lungs. So if we ventilating patients for non-pulmonologic indication, we have to put in mind also that the ventilatory setting might be very injurious, and you end by having a stroke intubated for a protection of airway, but then you introduce lung injury or ERDS. And the clear message that I understood from the presentation is that we have to put in mind that we individualize the care, and no one size can fit everyone. So probably that's what meant by going at the end of the game with the driving pressure better than we go with the other parameters like high PEEP versus low PEEP. At the end, you need to maintain the driving pressure, which is the difference between the plateau pressure and PEEP, less than, as much as we can, 15. Here, I see a question, two actually questions, asking about the COVID-19 patients. Is there any things that makes COVID-19 patients a special category of patients, and we have to do certain protection more than what we inherited since Amato presentation or paper on New England Journal of Medicine 20 years back? Is there anything special for COVID-19 patients? Pneumonia, ERDS, Dr. Yehia?
Yes, Dr. Ashraf. I'm going to cover this in the second part of the lecture in the application of the strategy. So I tried my best not to talk too much about coronary, because I know if we talk about corona, that will take the whole session alone, you see. Yeah. So I'm going to explain how we are going to use this strategy in the corona patients in the second part of the lecture.
Great. I see one question here asking from Dr. Muhammad Ahmad Ali. He is asking if there is any difference in protecting the lung if we apply or use a control, volume control versus pressure control. Is there any superiority of any mode over the other in lung protection?
Yeah. Yes, this is the second message that I wanted to present here. The evidence does not have enough finding to prove that the pressure is better than volume. However, as I explained, it is more logical that to use the pressure control in the ARDS or the corona patients. I know that the guidelines that were published by many of the very respectable societies, they were putting the volume control in the guideline. But the reason is not because the volume control is better reason was because of the multiplicity of the cases that flushed all the intensive care, and they were obliged to bring doctors who are not even working in the ICU to manage this patient. So the target was to use the simplest way to guarantee safety of the patients. That's why they mentioned volume control. It's not because volume control is better, but because people can learn to manage patient on volume control faster than the pressure. The pressure control means more skills and more details about how to manage this patient. But I believe that pressure is more beneficial. The corona, the most characteristic finding in the diagnosis is the crazy pavement CT scan, which means that there is a marked heterogeneity between the areas of the lung affected. So if we use a volume control, we are trying to induce injury in this patient. And so let's, for the time being, until we talk about the corona, consider that pressure is the preferred mode.
Okay, thank you very much, Prof. I have a question here from Ahmad Mohammed. He is asking about the optimum PEEP. Are you going to cover this next presentation?
Yes,
Professor?
yes, I will give them how to calculate it and how to adjust it clinically in the patients, yes.
Ismail Higazi is asking about prone in ERDS. Well, I don't think this is in coverage of this presentation.
No, I don't think.
Although prone.
Prone is a part of the management. I will talk about it with the management of the ARDS.
But it's an excellent question, actually, if we consider prone as a protective way of the strategies.
Yes, because there is something new in the proning, which is the awake proning. The indication for the prone for 12 to 16 hours in the ARDS patients have been modified for the patients with corona that are spontaneously breathing and not intubated. So you prone them, you ask them, you just tell him, sir, could you please turn your face down? You see, and then you leave him as long as he can stand it. In a paper, this was calculated to be around 4 hours. But there is a marked improvement of oxygenation. I want to say something. Oxygenation has nothing to do with survival, but oxygenation is important to maintain the system of the patient. So if we feel that we have to increase the oxygenation or the SpO2, that's fine. But do not put it as a target, because this is not going to save lives. Sometimes we do more injury by trying to reach a saturation of 100% or a PO2 of 100, more than the benefit that the patient can get. And this is very special in corona. I feel that there is an urge to manage the oxygenation, and this might cause problems, especially in what I call the golden hour of the corona, which is the hour, the transmission between high nasal flow catheter or Walid, is everything is okay, or because I felt that the screen went out.
All is good. All good.
Okay. The changeover from the time of ventilating the patient with the nasal cannula or high flow nasal cannula to non-invasive ventilation, this is a very critical time. If you do not detect what's happening in the patient at that time, you will shift him to the other type of corona, the H type.
Great. I like to emphasize more on this very important message, if you allow me, Professor.
Yes.
That if we stick to the targets of management, then we protect the lung, i.e. the old recommendations are not saying that you have to have certain number of oxygen tension and certain number of oxygen saturation if it's above 88 to 90%. This
Yes.
is more than enough for tissue oxygenation. So
Yes.
people, they like, as you said before, people, they like to see saturation of 100%, where this is not needed at all. And in expense of having this 100%, they go and increase the PEEP unnecessarily, or increase the tidal volume unnecessarily, or they go with a lot of things that injury directly or indirectly the lung with no benefit. So thank you very much for emphasizing this, Professor Yehia. One of our colleagues here is asking to highlight more. He doesn't understand what's the driving pressure. If you just, in brief, Dr. Yehia, again, stress on this.
Okay. The driving pressure is the pressure calculated from subtracting the PEEP from the plateau pressure. So if you have a plateau of 20 and you are using a PEEP of 5, the driving pressure is 15. And this is the main parameter that is producing the lung injury. Because as I'm going to show you some videos in the second part, showing you what happened in the lung. We think that the lung, as we have always in mind, or when we see in the OR with the patient undergoing CABG, for instance, or cardiac surgery, and they open the chest and you see the lung is going up and down. This is what we produce. The lungs normally does not work this way. You have to consider that there is a total lung capacity, and the tidal volume is a small volume. So the movement of the lung is just a very small movement. It's not the drastic go up and down, you see. And if we produce this drastic movement by increasing the swings between high pressure and low pressure, high pressure and low pressure, which is the difference between them is the driving pressure, that will produce the lung injury. This is the main factor in the production of the lung injury. I hope I clarified it. Yes.
Yeah, it is very clear. I think it's very clear for everybody. I don't know, Dr. Walid, if we still have a few minutes before Dr. Magdi introduced the next presentation.
Well, you see, Dr. Ashraf, I'm sorry, because both subjects are related. So some of the protective will come after. I had to bring them later because they need to know the recruitment before.
Why we don't proceed to the next presentation? Walid, what do you think? Walid, Dr. Walid?
Yes, yes, for sure.
Now? Yeah.
Whatever suits Prof Yehia. If you feel there is no questions about specific about the last section, we can go ahead.
You will have more questions about the second part. So let's start now. And
so the mic is yours, Dr. Magdi Khalil, to introduce the second part of the tonight's presentation.
Okay, welcome, Professor Yehia Khater. As I've said previously, it is my honor to represent you, but in a social manner. I'll just tell all the audience that what we say about you in our social life, that Professor Yehia Khater is the Foreign Affairs Minister of Anesthesia all over the world. He represented well anesthesia in Egypt for all the world during the WAFSA, and also the Arab world and the Egyptian Society of Anesthesia. So I'm happy to be with him again and again in this. We usually used to have Egyptian conference all over the universities and societies. We just put Professor Yehia Khater and then we add other speakers to fulfill the program. So always with usually in conjugation with Professor Yehia Khater. Just before we go to the recruitment maneuver, many questions has been asked about the driving pressure. Please, Professor Yehia Khater, would you like to just highlight the importance of the definition of driving pressure, as some candidate asked about what is meant by, what is relevance. that I'm sure that you'll use it, driving pressure in the protective, in the recruitment maneuver. So if you please, you can go now, and please, you can just start by more definitions, more explanation about
driving pressure. Well, with the calculated driving pressure, that above which you are putting the lung of the patient in danger of injury, is 15 centimeter water. If we go back to the physiology, you will find that even this 15 is a little bit too high. I mean, we have to maintain the driving pressure below 15 centimeter. And the pleural pressure is 5. And the triggering pressure of the patient on the ventilator is 1 centimeter. And then the resistance of the tube is around 5-6 centimeters. So if you add all this, you reach around 11-12 centimeter. That should be the pressure that we ventilate the patient normally. So when we say a driving pressure below 15, how we can apply it? I'm going to talk, for instance, for the anesthesiologist. When you see your patient breathing spontaneously, you can see a swing of 1 centimeter below and 1 centimeter above. That means a triggering of 1 during expiration, the pressure is -1, -2. And then during expiration, it is +1 or +2. So there is a swing of 1 to 2 centimeters only. When you shift to the ventilator, you apply, to obtain the same tidal volume, a pressure of 20. And at that time, is the 20 centimeter water what is required by the patient, or that is an extra pressure that we give to the patient and we injure him? If you want to know the answer, subtract the PEEP from the pressure. So if you are not giving PEEP at all, then your driving pressure is 20, 0 or 20 minus 0, 20. The 20 are giving you, for instance, a tidal volume of 500. You are satisfied with the 500, but you are putting your patient under the stress of having injury. So what we usually do is that we calculate the tidal volume that we want for the patient. We adjust the driving pressure at 15. If we obtain that pressure, it's okay. If we does not obtain the pressure, then we have to do something to diminish the pressure in order not to increase the driving pressure. At that time, recruitment is indicated. If you recruit that patient, you'll find that your pressure will decrease. And at that time, you will have a driving pressure of less than 15. I am amazed because when I started to apply the driving pressure, I found that the 20 centimeter water that we use for the normal lung is too much. Most of the patients, they need 15, 14, 12, and that gives us the required tidal volume. So we are over enthusiastic in the ventilation and we produce more harm to the patient. Simply, the driving pressure is the difference between the plateau and the PEEP. But you have to work a little bit and think about what we are giving to the patient and if it is required or not. And if you adjust it properly, you find that you don't need to do anything more than this. Thank you very much. I think, Magdi, I answered.
Yes, yes, it's a very clear answer about that. So I just asked you to re-explain this because I'm sure that you will need this in the recruitment maneuver.
It will come, yes, it will come again. It will come again with nice pictures. And
just as one marker of the attendee number, we started by 225, and now the number of participants outside the moderators is 337. So more than 100 increased. That is a great achievement of the lecture. Please go and start.
Okay. Now let's go to the second part. I'm going to start with the lung recruitment. Again, I'm showing the Cochrane study. which prove that there is a benefit from the recruitment maneuver. Some people, they see patients who do not benefit from it, and this is right, because some patients are recruitable and others are not. I'm giving the example of the corona. Early in the disease of the corona, the patients are not recruitable. So if you do a recruitment maneuver for them, you won't get any benefit. But later on, the recruitment maneuver is beneficial for them. And the most important point that I would like to emphasize here is the individual titration of the PEEP. Every patient in each situation is different than the other. So, and the example, if you put a patient in Trendelenburg and then you put him on anti-Trendelenburg, do you think that the value of the PEEP required is going to be the same? No. If you put him on one side, lateral position, or if you disconnect him and then you suck the trachea, all these situations are going to give different situation for the calculation of the recruitment maneuver and the amount of PEEP required. That's a study that is mentioning what I mentioned already about the optimal recruitment maneuver methods and the effect of recruitment maneuver on clinical outcome are still under discussion, and no definitive guidelines for recruitment have been established. And again here, the stepwise recruitment maneuver recruit lung units as effectively as sustained inflation with a lower mean airway pressure and less side effects. What does this mean? We have two ways, either the rapid recruitment or the slow recruitment. Nobody proved that any one of them is better than the other. However, we know, and that had been proved, that the side effects with the slow recruitment is this. So if I have the choice, I will choose, if there is no result in the outcome, I will choose the method of the least side effects, whether hemodynamic or respiratory. What are the recruitment maneuver? This is the recruitment maneuver described originally by Amato. And he is ventilating the patient. Here I choose, for instance, a PEEP of 5 and a plateau pressure of 15. And then he raises the pressure to 40 centimeter water and maintained it raised for 40 seconds. To open an alveoli, you need pressure applied for time, a certain time, which might differ from one alveolus to the other. And this is what we call the rapid recruitment. Now let's go to what is the slow recruitment maneuver, or the stepwise increase in PEEP. Here we start by adjusting, for instance, 0 PEEP and an inspiratory pressure of 15. By the way, the stepwise is done usually using the pressure control mode. So you adjust 5 and 15. And then the first thing you look at is the compliance of the lung. Most of the anesthetic machine now can measure the dynamic compliance of the lung. So you have a figure and you look at it, you'll find 17. Even those machines who does not show it, they calculate it, but you have to look at it and then put it on the screen because it is hidden. So you increase after 5 breaths, 5 centimeter PEEP. At that time, you are ventilating at 5 and your plateau pressure is going to be, or inspiratory pressure is going to be 20. And you look at the compliance is 22. You increase 5 again, and then you have 10 PEEP and 25 plateau. And you increase 5 again. Every time you see that the compliance is increasing. Now you increase 5 and you find that the compliance has decreased suddenly. So what happened? Now you have to look to the pressure volume curve. You reached the upper inflection point of the curve. Any increase here is going to increase the pressure much and will not increase the volume. That's why the compliance dropped. So if this if this occurs at any time during these steps, or if any hypotension occurred, you have to abort it. If hypotension occurs, this is an indication that your patient is not well hydrated. You have to infuse him first before you apply it. And if it occurs because, and if the drop, if the compliance occur, this means that you reached the upper point and you have to end the maneuver here and continue down. But if it doesn't, then you will continue adding 5 again. So 5, 25 PEEP and 15 driving pressure, it will reach the 40. So we reached the 40 induced by Amato, and we did it slowly by rising step by step. This is better tolerated for the hemodynamic and is better even observed from us and allow the patient to adapt to it. Now we know that we reached the peak. The lung now, all the alveoli are open. So this is the open theory. We open the alveoli. And then we have to go down. And we go down 5 by 5 for 3 times. And when we go 2 by 2. Because we want to measure a point here, that when we reach this point, suddenly the compliance. When you go down, the compliance does not change markedly. It's 40, 41, 42, 45. But then suddenly it will drop to 30. When, or even more, I'm giving just an example, you see. What happened here? When it dropped in the compliance, you reach the lower inflection point of the pressure volume curve loop, which means that the lung of the alveoli of the lung will collapse below that level. So now we know where the alveoli are going to collapse, which is the level of PEEP that we have to give. Here the alveoli are collapsed. So we need to redo again 5, 5, 5, 5 until we reach the 4, and reaching the 40. Then we adjust the ventilator at that level for the PEEP plus 2, which is the level before the alveoli collapse. And then we add to it the 15. So this patient, if this is 8, then we have to give 10 PEEP plus 15, it will reach 25. And we ventilate the patient on this level between 10 and 25. If this is 6, for instance, then we put a PEEP of 8, and then we add to them the 15 driving pressure, and we ventilate that patient at between 8 and 23 inspiratory pressure. It looks that it is too complicated. It's not. The whole maneuver takes around 2 to 3 minutes to be applied. And even the producing companies of the ventilator and anesthetic machine now are incorporating in the machine what they call the maneuver tool. So you have just a button, you press it, and then it will do the recruitment maneuver and give you the best result obtained. You have to also only to adjust that you want a respiratory rate for 15, for instance, an I ratio. Inspiratory pressure, it's 20, which means 5 plus 15, 25, 5 plus 10 plus 15, and 15 plus 15, 30, and then you go 20 plus 15, 35, and then you go down. And at that time, you have the lower inflection point and the higher inflection point, which are the limits where you can ventilate your patient in between. So this is how to do the recruitment maneuver. Are we going to repeat it, or we do it once? Well, let's talk first about under anesthesia. The best time to do the recruitment maneuver is immediately after intubation, because that is the time after the pre-oxygenation, most probably with 100% oxygen. So you are producing atelectasis in the patient. And if you do it after the pre-oxygenation and the intubation, then you won't need to do it again until the end of the operation, unless you change the position of the patient or you do suctioning. Otherwise, that once is enough, and then you continue until the end. But if you change the position, then the level will change. So you have to repeat it to find another level. Or if you do suctioning for the tube, then you will be obliged to do that maneuver again. In the ICU, it's different. You have to define, is this patient is recruitable or not? And if you do it and the patient improve, then you do it again when the patient starts to deteriorate. That's obvious, you see. And I think that this is the titration. I hate to say we have to do it every day or we have to do it every 12 hours. Every patient is a special case, and then we have to follow him. Now I will show you the importance of the proper adjustment of the PEEP. And how does the alveoli work? This is a live or in vivo video taken in from lung pigs. They open a small incision in the chest and they introduce a microscope and they look what happens to the subpleural alveoli. So look and concentrate on the size of the alveoli, what will happen in them. There is no drastic movement. It's a small movement. And this is the first video is a normal lung. Okay, now let's go to the same lung of the pigs where they did a bronchial lavage and they tried to produce a situation similar to ARDS. And now look at the alveoli. You don't see them, and then they will do a recruitment maneuver and you will see that the alveoli are opening. Some of them will take even a longer time to open. So you see, the maneuver is opening the alveoli, and it takes time. Here, it took the longest time. But now we want to maintain this alveoli open. And to maintain them, we have to apply a PEEP and the PEEP pressure. I'm going to tell you that this lung needs a 10 centimeter water PEEP pressure. So we'll start by giving the patient or the animal 5 centimeter water, and look what will happen. So 3 things to get from this video. First, there is a market movement, and the market movement is coming especially in this year, and because there are areas that are collapsed. So the volume which is supposed to go here is going to the healthy one. And this is hyperinflation of the healthy one. And still there are some alveoli that are not open. Let's now recruit the lung again and then apply 10 centimeter water PEEP, which is the value that is required by this lung. Look now. So what happened here is the movement returned to the first video, very small movement between the end inspiratory and the end expiratory. Most of the area are recruited and there are no hyperinflation in the alveoli. And this is what we want. This is what we want from to our patients. Let me return again to the study of Amato. It was written on it that non-recruitable and recruitable. And this answers the question, how we can find the patient who are recruitable or not recruitable. The golden standard is that you do a CT scan. CT scans are not available in the ICU and not available in the OR, in most of the OR. And we cannot repeat it every now and then, every hour or a couple of hours. Let's send the patient to the CT scan to get to know if it's not practical. So what is practical really is that we have to rely on other things. So the first one is the clinical sense. When you increase the PEEP and the plateau pressure does not increase, this is a recruitable lung. But when you increase the pressure and the plateau pressure increases markedly, that's a non-recruitable lung. So this is the first impression that we get. And then doing the recruitment, if you go 1 or 2 steps and then you find that there is no improvement, the compliance does not improve, the blood gases does not improve, then this lung is not recruitable. There is no need to proceed. There is a tool that is coming very efficiently in the management of the patient in the ICU, which is the use of the ultrasound. And I'm not talking about ultrasound, but I am going to emphasize on the 2 things, you see, that we can see the aerated area and the sub-aerated area by the ultrasound. We can see the B lines in the ultrasound, which means that there is a consolidation or interstitial fluid in this area. So this might help. We can see also by the ultrasound the movement of the diaphragm. So we know if this is a good ventilation or not a good ventilation or a hyperventilation in the patients. And then there is the electrical impedance tomography. The electrical impedance tomography appeared maybe more than 20 years, but at that time it was used for the measurement of cardiac output. And now it is used for the follow-up and the measurement of the recruitment. The technique comprises the application of a belt around the chest of the patient with 16 electrodes. And then you emit an electrical current from each electrode and you measure it from all the others. What is the importance? The chest is composed of alveoli and blood vessels, and interstitial fluid around the alveoli. So if the air is more or increased, the passage of the current will decrease. And if the water increase, then the passage of the electricity will increase. So we start by 2, and then we shift to the others. We use after this 2, and we emit from them to the other 14. And we measure every time the electricity. You tell me what's the importance. This is the importance. This is the area of hyperinflation, which is white. The area of normal inflation, which is blue. The area of consolidation of atelectasis, which is black. So now, if we turn the color, the current around the chest, and by changing the 2 emitting electrode, we'll end by having a picture at the end of area of hyperaeration, area of normal aeration, and an area of collapse. Apply this now to the lung. So this is a lung of a patient where the left lung receives 50% only of the tidal volume, and the remaining 80% goes to the right lung. As you see here, there is a small area of the lung which is aerated. The other part are collapsed, and this is a hyper-aerated area with a normal aeration and a very small collapsed area. Now, this is a pre-recruitment. Let's go to the recruitment. After the recruitment, what will happen? Here we were using an FeO2 of 0.6 and the SpO2 was 87. Here we are using an FeO2 of 0.35 that decreased, and we have an SpO2 of 98%. And the lung received, now the left lung received 30% of the tidal volume. 4 hours after the recruitment, now we get this picture. You see that the area of hyperinflation is reduced much because the air now is going to the recruited alveoli. These are the area of recruited alveoli. And this lung is receiving now almost half of the tidal volume. So we corrected the situation. At an FeO2 of 0.35, we have an SpO2 of 99%. I'm showing you this because these machines appeared already in the ICUs, some of them, and they are used. And this is going to be the future, how we are going to assess our recruitment. Now I will go to the last part of the presentation, and I'm going to talk about 4 models: the obstructive lung disease, the restrictive lung disease, the normal lung, and then a few words about the corona. Normal lung. We anesthesiologists are atelectogenic. We induce atelectasis, and we do not realize this. Sometimes we are pre-oxygenating with 100% oxygen, and that's the worst thing that we can do because you are filling an alveolus, and then there are a period of 2 to 3 minutes during the intubation where there is oxygen. There is no oxygen coming in, so there is a marked absorption of the oxygen and then a production of atelectasis. Then you will tell me why we don't notice it. I will give you the explanation in a while, but first look here. These are the CT taken of patients before anesthesia. They are awake. This is normal lung. There is no atelectasis here. And now this is the induction of anesthesia followed by a recruitment. Look, the result of the induction of anesthesia, you have atelectasis in the 3 groups here. These 3 groups, after the recruitment, one of them, they give them PEEP. The second, they give them recruitment maneuver with 0 PEEP. And in the third one, they give them recruitment maneuver with PEEP. You can see that atelectasis continues in all the group except the middle one, which is with the recruitment with PEEP, that resulted in disappearance of the atelectasis. So this is the normal lung that we are dealing with under anesthesia. This is there first, it's not infrequent It occurs in 90% of the cases, but the range is variable between 4 and 20%. So if a patient has 4% atelectasis, you will never notice it. And it occurs early during the pre-oxygenation in the dependent lung region. It is favored by a high FeO2, and the management is to recruit and apply the proper and titrate the PEEP. And why we do not notice it? Because atelectasis results in alteration of the ventilation perfusion ratio. But we are still on the horizontal part of the oxygen dissociation curve. So there is no marked difference. That's why we don't see it. But now, if it happened that the patient is hypoxic and we cannot intubate or we do not intubate properly, then he will go to the steep part of the curve, and then you will find the hypoxemia occurring very rapidly. Is there an evidence for this? Yes, like Amato, Serpaneto. He did the same work of Amato, but at this time he did it for the patient under anesthesia. And the difference is that under anesthesia, we cannot take the outcome as the mortality and survival. We have a very low survival and mortality. And he took the outcome as the post-operative respiratory complication. He resampled around 2,000 patients, and he resulted in the same result of Amato. It's not the compliance, it's not the tidal volume, it's not the plateau pressure, it's not the PEEP. What is significant really is the driving pressure in these patients. So for normal patients, there are a lot of papers that prove that we have to use it in normal patients and in patients at risk of acute lung injury. But I believe that this one is the most beneficial because it proved that we have to use the protective strategy in its modified way by using the driving pressure. Why they took the outcome as the post-operative respiratory complication. This is a paper that was published in 2005 by Khoury, and he showed that the occurrence of a 30-day complication, respiratory complication, reduced the median patient survival by 70%. Can you imagine that you admit a patient for appendicectomy and then you tell him your survival will decrease by 70% after 10 years? And this what was noticed in this patient. If they have a post-operative respiratory complication, the survival risk is increased by 70%. Now we are following a lot of patients with pre-operative preparation, with pre-operative assessment, intraoperative management. But tell me, is there any one of this who can affect the outcome by 70%? I think that this is the most important factor that we have to consider in our patients. Now let's go to the ARDS. Well, these are the 7 P's of the ARDS. And the 7 P's is the management of the patient with ARDS. It is the prevention, the PEEP, the pump, and the pipes. Here the heart and the vessels. I will take the one only in red, and then the nutrition. I'll take the one in red because this is what is related to the ventilation. The first item is prevention. And here we talk about predisposing factor. You have to manage the predisposing factor. And early diagnosis, the best diagnostic value is to take the PaO2, FeO2 ratio. All of you, you know this, that less than, above 300 is normal. Between 300 and 200, that's a mild ARDS. Between 200 and 100, that's a moderate. And then below 100, it is a severe ARDS. And for standardization, we have to do it with a PEEP of 5. There is a new value that appeared during the era of the corona, which is the SpO2 FeO2 value. And this is very valuable for the screening of the patient, because you just put the oximeter on the finger and then you calculate this patient has to go to the ICU or has to go to the floor. Because if you find that the SpO2 FeO2 is less than 315 in adult or less than 264 in children, that means that that patient is going to or following the way of the ARDS. And then the last item is to apply the protective lung strategy. FeO 2.8, tidal volume 4 and between 4 and 8 milliliter. The PEEP, you have the evidence which say that if it is a severe ARDS, use a high PEEP. I think that the titration is more beneficial, but this is my own opinion. There is no evidence up till now. The driving pressure is of importance, that you have to maintain it below 15. And then the question comes, if I cannot maintain it, some patients we cannot maintain it. Okay, you have to do your best, but if you have a driving pressure above 15, that's the patient who will have the highest mortality. And then we go to the respiratory rate. It was always mentioned that a high respiratory rate is advised in the ARDS to maintain the oxygenation. According to the work of Gattinoni, that is suspicious, you see. So we need to increase the respiratory rate, but a lot of people now suggest that we do not have to increase it more than 20. And then the last two items related to the ventilation, which is the PEEP. We mentioned it as recruitment and titration. And then the paralysis. I believe that the paralysis here is a lack of our diagnosis for the patient ventilator asynchrony. I don't like that you rush to muscle relaxant because the patient has a ventilator idiosyncrasy. The diagnosis of idiosyncrasy takes time, and if you concentrate and observe the patient, you might find a reason that might let him fight the ventilator before that you give him the muscle relaxant. Now we come to the star of the era now, the corona virus. And I think that Hippocrates, when he said, first do no harm, this applies to what we have to follow in these patients. We might add to them, second, prevent the patient's self-induced lung injury. I'm going to present to you a study that was done in 88, and this study was done on animals. And in this study, they proved that if they induce hyperventilation in the animals by pharmacological drugs, you see, then the resultant lung injury is very similar to the ARDS. When we talk about corona, only there are two suggestions of the mechanism of occurrence of this. Either it is a self-induced lung injury, or it is an imbalance between the vasodilator or vasoconstrictor in the lung, which result in vasoplegia. And the vasoplegia will result in dilatation of the vessels. And when this occurs, there is congestion, slowing of the blood, maybe microemboli in the small vessels. And there is also interstitial edema that might go to inside the alveoli, and then you have alveolar edema here, which is the picture that is presented during the corona. So it's almost the same as the ARDS, but in ARDS, it starts in the alveoli, and here it starts outside the alveoli, and then it goes to the alveoli. What's important to notice here is the swings in the ventilation. This is the airway of the pressure, airway pressure, and this is the esophageal pressure. And when we look at what happens, if the patient is doing a marked work for breathing, then there is an increase, a marked increase in the esophageal pressure. And at that time, what we see is only the effect of the airway pressure here, but we don't see this hidden area. So the swing is now increasing markedly, and this induces the lung injury. I showed you this because I believe that this is an important explanation of what's happening in the corona, something which I used to look at it and something is missing. This must be the answer. Again, this is my explanation. There is no evidence for it. We are looking for the evidence that will come in the next few years, either to approve this or to deny it. Let's go to the COPD. When you manage a patient with COPD, the most advised mode of ventilation is the non-invasive ventilation. This is really where the invasive ventilation is superior. A pressure support CPAP or a BiPAP is the best choice. But remember that these patients, they have a normal compliance, even a higher compliance in the lung. They do not need a market pressure, so you have to minimize the support. A patient selection is important because not all the patient can adapt with the application of the devices to deliver the CPAP and the pressure support. And most importantly is this, the increase the respiratory sensitivity. I will explain it later on in details. Now, if you go to invasive ventilation, the same apply. You have indication, and then you have to increase the expiratory time to decrease the inspiratory time. You cannot do this unless you slow the respiratory rate and then counter the intrinsic PEEP with external PEEP of 70 to 80% of the intrinsic PEEP. This is generally how we manage these patients. But let's go in more details. This is the airway pressure as measured from our endotracheal tube. And this is the esophageal pressure as measured from a catheter introduced in the esophagus. Now, this is a normal patient. The patient wanted to breathe here, so he started the contraction of the diaphragm and the esophageal pressure decreased. And the ventilator usually responds very quickly after this, so there is no time lag between both of them. And when you reach 70 to 75% of the cycle, then the patient is now requesting to expire, so he starts his expiration. Look what happened in the COPD. The diaphragm has started to contract here, but the ventilator responded here. And why all this delay? The delay is due to the presence of the intrinsic PEEP, because the presence of intrinsic PEEP means that the diaphragm has to originate pressure higher than the intrinsic PEEP in order to trigger the ventilator. So if you have an intrinsic PEEP of 8, that means that the diaphragm has to produce -9 centimeter water in order to trigger the ventilator. So there is this delay. You might say, that's the problem. We are breathing at 1 centimeter. Now the patient is doing 9 times more effort to get a breath. If you get it for a sequence of breaths, you can imagine the work of breathing done. And again, now the patient wants to expire here, but the ventilator is continuing to give him the task set by the intensivist. So the patient will fight the ventilator. The solution, Now, if these patients mainly are using a pressure support CPAP, the only way to control a spontaneous breath, that might be easy when you use a controlled mode. But the only way to control spontaneous breath is that you increase the expiratory sensitivity. So by definition, pressure supports the ventilator cycle when the flow drops to 25%. It's easy. We make the flow 50, 60%. And at that time, the cycle will end here. So it will coincide with the expiratory requirement of the patient. Yes, the support will decrease, but who say that these patients need oxygen? They have a problem in oxygenation. The problem in oxygenation comes from the accumulation of the CO2. It doesn't leave a place for the oxygen, but not the reverse. So even with a small support, with an extrinsic PEEP, 80% of the extrinsic PEEP, prolongation of the expiration and lowering of the inspiration, this is the proper management of these patients. So we come to the last two slides. This slide is how we manage all the patients. If we have a patient of hypoxic failure, which is most probably restrictive lung disease, then the tools we have is either to increase the FeO2, we have limits in this, or to increase the mean airway pressure. And to increase the mean airway pressure, either you increase the tidal volume or you increase the plateau, you increase the inspiratory time, you increase the flow. And if you notice that all of this are a member of the protective strategy. So the protective lung strategy would like that we control all of this to protect the lung. And if we need to oxygenate the patient, so we have to resort to other maneuver. So either we recruit the lung to lower the pressure that we want to increase, or to use the prone position to improve the oxygenation of the patient. When we go to the other extreme, the hypercarbic obstructive lung disease, in normal lung, it's easy to control the CO2. You have to increase the minute ventilation. So you increase the rate, you increase the tidal volume. But this is the reverse, exactly what you have to do in COPD. Because at that time, you have to lower the support, to lower the respiratory rate, to choose a long expiratory time, and to add an external PEEP, and to increase the expiratory sensitivity. When we come to the corona, to the normal lung, I gave the example of the patient under anesthesia, and you have to apply the protective lung strategy and recruitment. And then for the corona, you know that there are two types or phenotypes of corona. The L type, which is characterized by low elastance and low perfusion, ventilation perfusion ratio, and low recruitability. These alveoli are healthy alveoli, so we don't need to recruit them. And then the phenotype, which is the reverse completely. If we talk about the corona, there are two types of ARDS, atypical type and atypical type. When it reaches the H type, it's atypical. And the area in between these two is the atypical ARDS. And this is the time when you give the patient oxygen and he fails to maintain 92% oxygenation. You give the high nasal flow caster, he fails, and then you shift it to non-invasive. And when you shift to non-invasive, you have to try it for 30 to 60 minutes. This is the golden hour. If it fails, then proceed to intubation. Because if you don't do it, you will cause more problem to that patient. Last slide and take home message. There are things in ventilation which in which one size fits all. So the volume 4 to 8 milliliter of the predicted body weight, that fits all, whether adult, pediatric, male, female, obese, all of these patients, the 4 to 8 milliliter apply to them. And then you have the driving pressure, which is a consecutive to the volume, which is less than 15 centimeter, and it fits all patients, normal, restrictive, obstructive. You have to maintain the driving pressure below 15. And then there are things that one size does not fit all. And this is the PEEP. It was originally mentioned that we have to use the high PEEP in ARDS. And we use a PEEP, which is 80% of the intrinsic PEEP of in COPD. In both conditions, we have to titrate the level of the PEEP to know the answer of this question. And then the respiratory rate, it was a slow rate in COPD and high rate in ARDS. Now we say slow rate in COPD, high, but with limit rate in ARDS. And I don't see why Corona will differ from all these general rules if you understand the staging of the patient. And thank you very much for your attention.
Thank you, Professor Yehia, for this recruitable lecture, which awaken our brain cells about the importance of VLI as a fact, not as an exception, and also the protective lung strategy that should be taken into consideration even with normal lung tissues. Now I think it is time to get 1 minute of deep respiration. Is it okay to take deep inspiration, or
yes,
just enough?
Yes.
But without smoking.
It's okay. No, you see,
I'm sure now that in the Gulf area, we exceeded midnight, but I'm sure that Professor Yehia Khater has recruited all the sleepy person to share with us all the 2 lectures. Now I'll go to the questions. Then due to lack of time, I'll skip some questions that are not related to the topic. And I promise that Professor Yehia can answer, but I'll go to the asking from Ismail Higazi, what is the parameter using adjust and titrate PEEP in the lung protective strategy? I think this has been cleared, but if it is a little bit not obvious, can you repeat, please explain what is the parameter using adjust titrate PEEP in lung protective strategy?
It's the compliance of the lung.
Okay.
You titrate the PEEP according to the compliance of the lung. So you give 5 PEEP and 15 driving pressure, and just look at the compliance. If the compliance is 20, then you add another 5. If it is increasing, you increase again another 5. If it's not increasing, that's a patient who is not recruitable. Okay, but if it increases, you go by 5 until you reach a pressure of 40. This is the maximum. And then you go down.
Another question about PEEP, how to measure PEEP.
How to measure? I beg your pardon?
How to measure PEEP to overcome O2
to overcome O2 PEEP. Okay. The intrinsic PEEP is measured by the ventilator. And there is a theory called the waterfall theory. I know that most of the people, they think, how can we manage an intrinsic PEEP by the addition of PEEP? But it is explained by the waterfall. If you have water coming from a very high level, and then in a lake, do you think that the flow of the water is going to differ if you raise the lake? No. When it differs, if the lake is at the level of the waterfall, at that time, there is no flow of water, you see. And that's why we say 70 to 80% of the measured intrinsic PEEP. If you have a measured intrinsic PEEP, you have to apply 8 centimeters. If it is 10 centimeters, you apply 8 centimeters to the patient. The other reason for this is that not all the alveoli have the same average or the same level of intrinsic PEEP. So we better take a median of the alveoli so as not to hyperinflate those alveoli who has a bigger amount of air trapping. So this is the calculation. It is 80% of the measured intrinsic PEEP.
Okay, so going back to the 80% of the intrinsic PEEP, how to calculate the intrinsic PEEP? There's another question.
The intrinsic PEEP is usually calculated by the ventilator by an addition of expiratory hold. The PEEP, intrinsic PEEP, means air trapping in the alveoli. So even if at the end of inspiration, at the end of expiration, we close the inspiratory valve and we close the expiratory valve, at that time, the pressure present in the circuit is representing the pressure of the air trapped in the alveoli. So if you apply the expiratory hold on the ventilator will tell you the intrinsic PEEP value is 8, 10, 6, whatever the situation.
Another question about from Muhammad Ahmed Ali. Is there any difference in plateau pressure on obese, between brackets, or any patient with increased intra-abdominal pressure and normal weight patient? Another way, can we expect high plateau pressure in these patients?
Yes, but we are not talking about plateau pressure. We are talking about driving pressure, you see. So it's obvious that if the thoracic compliance is decreased, as what happens in the obese patient, so this means that you need a higher pressure. But remind you that the lung does not grow when you increase in weight. The same lung is serving you, the same size of the lung. This does not mean that you have to inflate this lung with a higher volume because the patient is obese. And that's why we say 4 to 8 milliliters of a predicted body weight. The predicted body weight, there are a lot of equations that calculated, but I like simplicity. If you have a patient of 160, the length of the patient 160 centimeters, his predicted body weight is going to be 60. So if you have a patient of 150 kilo and his length is 160, at that time, the required tidal volume in this patient is 60 by 4. You see, it's very by 6, so 360, you see. So 360, although he is 160 kilograms, you can imagine now how much harm we do to this patient when we give them a tidal volume of 600, 700. And this is not rare. There is a study which was done by Sami Jaber, and he found that the people they suffer most from the use of high volume are the ladies and the obese patients, because at that time the calculation of the anesthesia is usually impressed by the size, you see.
Another question about the increased abdominal pressure also. Will we keep driving pressure 15 with lap surgery also? And my comment about that, would you, Professor Yehia, prefer to recruit before inflation or after inflation?
Okay. Well, let's, I missed something in the answer of the obese patient, and there are some variation in the driving pressure. When we say 15 centimeter water, this is the majority of the patient. But the person who asked that question, I think that he is understanding well, because he mentioned intra-abdominal pressure, and he mentioned the obese, you see. And in these two conditions, if you measure the esophageal pressure in them, then you will get a level which is higher than when you expect for them. And these are the conditions that measuring of the esophageal pressure will prove the value of the driving pressure that you are going to use. Because the level of PEEP that you will decide, it's not the driving, the level of PEEP that we are going to choose might be higher than what you expect. And you cannot measure it except with esophageal pressure. So this is the first answer. Now, recruiting before inflating the lungs or after. I will recruit before and after. Before, to overcome the atelectasis that we are inducing. And after, to manage the atelectasis that will result from the inflation of increasing the intra-abdominal pressure. So instead of extubating the patient, because now you decrease the intra-abdominal pressure, so the diaphragm will come down, but still there are alveoli who are collapsed and they need a higher pressure to be open. So you open them, you save the patient a lot of respiratory complication afterwards.
Okay, another question from Islam Ibrahim, increasing respiratory time versus increasing PEEP, which is you to prefer to improve oxygenation?
Both of them improve the oxygenation. There are two factors that make the increase in the mean airway pressure. Which one to use? Well, if I titrate and then I find that the PEEP required is 8, and then I give the patient 8, and then I'm not yet satisfied with the level of oxygenation, then I will increase the inspiratory pressure. And the reverse, I might start the reverse. I might increase the inspiratory pressure, but the increase in inspiratory pressure at that time might decrease the expiratory time so that you have an intrinsic PEEP, iatrogenic intrinsic PEEP. You are inducing the intrinsic PEEP because you are limiting the expiratory time. So at that time, I will lower the inspiratory time and add a PEEP. So you cannot say that I'm going to use one of them better than the other, but according to the situation of the patient. And this is what we mean by individualized PEEP titration and recruitment, you see. So every patient is different. You have to manage him according to what he requires.
I think it's time to leave. We have many questions, but I think it's too late to answer some questions that will be answered to you or sent to you by email, and you can answer. That's because some of them, or most of them, are outside they are in the field of ventilation, you know, but they are outside the scope of this topic. I think it is well said that you attend with us and answer all questions. If I leave the questions, we might spend up to the morning tomorrow to answer the questions. So
I will be happy, Magdi, that you send me the question by email, and then I will answer them.
Thank you, Professor Yehia, for attending with us. Thank you all. The most lecture that has been attended by all speakers, more than 11 speakers, and they spent all the night up to the night, and also the attendee extended from 2:25 to 3:37. That's a great achievement. Thank you, Professor Yehia. Thank you, speakers, for attending with us. I wish it to be repeated again and again next weeks. Thank you, all of you.
Thank you very much.
Thank you.
Thank you very much.
Thank you, Professor.
So I do really appreciate your presence tonight, Prof Yehia. And before we close this session, I just want to share the new faculty. So the faculty in its new shape. So it's our pleasure to announce Prof Magdi Khalil as one of the session moderators recently added here to our. So Prof Magdi Khalil is a good asset to the Anesthesia and Critical Care Refresher course and Saving Lives Academy since the beginning. So I'm so happy that he accepted our invitation to be with us tonight, and inshallah for many and many more sessions. Welcome to the Scientific Board, Prof Magdi. And thanks a million, Prof Yehia, to be with us again tonight for a full session. Thanks to all our attendees, all our professors and colleagues in the panelist section and in the attendees section. Please always visit the website savinglivesacademy.com to find updated recordings of the lectures for the previous sessions and for the coming sessions soon as we can. Thanks very much and have a good night, everyone.
شكرا جزيلا. شكرا.
Goodbye.
شكرا دكتور يحيى. شكرا.
Thank you very much. Thank you very much,
sir. Thank you very much.